The next 40 minutes, we shall have a bonanza of ECGs from Dr. Narsimhan. I request Dr. Munna and Dr. Debabrata Bera to introduce Dr. Narsimhan's session, please.
Yes, sir. Good evening. This is Dr. Munna. Myself and Dr. Bera both are very much privileged to share this to chair this session. Dr. Narsimhan needs no introduction. Without further wasting time, I will ask sir to start off the session immediately.
Thank you so much, Dr. Deb and Munna. This talk again is predominantly oriented towards physicians to recognize some of the cardiac conditions readily in a busy practice. And cardiologists, please pardon if some of them are very, very basic. So this is a patient who came with an vague chest discomfort and sweating. And then because hospital was nearby, he walked in within the first half an hour after the onset of discomfort. So the choice is given. Do we have a choice for MCQ or audience poll? If not, I'll just go ahead. So this is a very important ECG sign where Deventer described this as an acute hyperkalemic change, but restricted to 2-3 leads. Please remember, when there is an acute ischemia and the vessel is occluded, there is a lot of acidosis there and the potassium elutes from the cell. If that happens within a localized area, you will find something like hyperkalemia there. Typically a tall peaked symmetrical T wave and a very minor ST depression, and the effacement of the ST segment. You see the QRS merges into the T wave. All these things suggest that there is a regional ischemia which is very acute. Even before the infarction happens, this ECG changes are present. And the importance of recognizing this is, if you revascularize this patient, quite likely you can abort an infarct. And the treatment here is immediately give a nitrate if the patient is a smoker, recheck the ECG and get the cath lab activated. Very rarely you may have resolution of these changes if there is a resolving thrombus, but 9 out of 10 you need to take them to the cath lab for early revascularization. So Deventer's group from Wellens, Netherlands, described this as an upsloping ST depression in precordial leads, peaked anterior T waves in the mid precordial leads V2 to V6, with the ascending limb of the T wave starting below the baseline, the ascending limb of the T wave starting below the baseline, and subtle ST elevation in AVR. This is a typical Deventer T wave, and the patient is acutely ischemic. You need to rush him with anti-ischemic therapy and rush him to the cath lab. This is a patient with orthopnea, severe mitral regurgitation. This is one thing which I would like you to remember. Of course, here it's very dramatic, an ST depression. But if you look at the R wave amplitude in V2, it's much taller and the T wave is upright. This should make us suspect that you're dealing with a posterior wall infarction. And these patients, when they develop mitral regurgitation, it's an urgent indication to revascularize because that papillary muscle is ischemic, and you may be able to abort an infarct and abolish the mitral regurgitation here. So this is a sign when you see a tall R in V1 and V2, accompanied by a tall T wave in the upright T wave, it should make you suspect you're dealing with a posterior myocardial infarction. This is inferior wall infarction with posterior wall involvement, and mitral regurgitation 9 out of 10 will get abolished or at least get minimized once you revascularize this territory. So how do you recognize ST segment depression, horizontal or downsloping like this case? Very prominent R wave in lead V1 or V2. RS ratio is more than 1. RS ratio is more than 1 in V2. Prominent upright T wave as was seen in this patient, and combination of horizontal ST depression with upright T wave. Usually this happens in the company of an inferior wall or a lateral wall MI. And when you're unsure, you may use V7 and V8 in the posterior location to document. Now, this patient presented to us about a year ago with rapid palpitation, recurrent atrial fibrillation, and you can see RR interval with ST changes. He was given loaded with drugs, heparin, and then given a beta blocker, and the rate came down. I would like to draw attention to the same fact. The STs are normal in V1, but very markedly depressed in V2, and the T wave is upright with a prominent upright QRS in V2. The next day, you find a completed dorsal infarction here in the same patient. The reason why this is important is to understand left atrial circumflex artery is a branch of circumflex, and that supplies the left atrium. When they become acutely ischemic, you can have atrial fibrillation as the presenting manifestation. Now, all the attention in this patient was devoted to atrial fibrillation. Someone forgot to look at the prominent STT changes, and this patient should have been rushed to the cath lab rather than treating him with more and more amiodarone in this patient. Unfortunately, it was a missed opportunity to treat. He had a completely occluded circumflex, which was opened much later. So when you have doubt what you're dealing with is an infarct or just an ST segment depression, ACS versus an infarct, you can just take an have the leads on V7, V8, and V9, which is in the interscapular line, posterior dorsal interscapular line, and that will show an ST elevation. And these patients, when revascularized either with thrombolysis or with acute PCI, you will have the same benefit as patients where this diagnosis was missed. Again, to physicians, the commonest misdiagnosis of myocardial infarction is dorsal wall myocardial infarction. The clues are prominent R wave in V2 in the presence of an upright T wave in V2. This is a 55-year-old person, presents with nausea and chest discomfort. So the diagnosis entertained, was it acute pancreatitis, pericarditis, acute coronary syndrome, or pulmonary embolus? So again, we would like to draw attention to this simple sign, which was described way back by Shamroth, which is called horizontality of ST segment. If any of the leads hug the baseline, normally the ST segment is supposed to be either smoothly smooth upstroke into the T wave, it merges, whereas if it hugs the baseline and it's very horizontal with a sharp uptake of T wave, that should make you suspect that this patient has an acute coronary syndrome. The second clue is a sudden diminution of the R wave from V2 to V3. The total QRS voltage suddenly comes down. All the company it keeps suggests that this patient has an acute coronary syndrome and actually had a tight LAD lesion. This is what I mentioned. In a normal patient, the ST segment smoothly merges into the upstroke of the T wave. Whereas in patients who are having an ischemia, there'll be a sharp upstroke and a very horizontal STT angle. Now, please remember, this doesn't mean always it's acute coronary occlusion. Severe subendocardial ischemia in a hypertrophied ventricle, severe subendocardial ischemia in a person with HCM can have all these manifestations. It's a physiological equivalent of a severe subendocardial ischemia. The same patient, left untreated, will lose all the R waves, and at the end of it, you will be left with a large myocardial infarction if it is not treated. Again, this is a patient with a left bundle branch block, presents with chest tightness for a brief duration. left bundle branch block morphology, which limits the diagnostic capability. But ST segment elevation that is concordant to the lead where the QRS is also upright should make you suspect that this patient has an lateral wall myocardial infarction, and he should be given either a lytic therapy or referred to a cath lab where the vessels could be open. So whenever you have an ST segment in a left bundle branch block with an upright QRS complex, QRS is upright and the ST segment is also upright, concordant to both the QRS, then this is a sign of an acute myocardial infarction in the presence of a left bundle branch block, and this patient would need to go to the cath lab. This is a patient who didn't have much of symptom. He came for a routine evaluation. However, he came for evaluation because 3 days prior, he had a mild chest discomfort while he was traveling. And the relatives brought him for a detailed evaluation. He's a diabetic on metformin and was on aspirin. He came for a master health checkup, and then would you do a stress testing or admit and observe, or would you refer him to the cath lab, or what will you do? Now, the reason why this ECG was put in was, again, when you see this kind of a T wave, symmetrical T wave inversion, which is a biphasic T wave inversion, in any of the precordial leads, this indicates the patient has a critical LAD lesion, and you should not do a stress testing on these patients. Not only that, you don't need further testing. This particular sign of a biphasic T wave indicates a large area of underlying hibernating myocardium, which means if you revascularize the patient, the LV function will completely normalize. So this is the importance of clinical observation. A simple electrocardiographic sign tells you a large area of myocardium is at risk, it is ischemic, and the muscle is completely viable, and you need to immediately revascularize. This sign is described by Hein-Wellens, and it's called Wellens sign. Two morphologies are described in V2 to V3, either a symmetrical T wave inversion arrowhead or a biphasic like this, up and down. If you see this, please do not put them through a stress test. Refer them for an angiography and revascularization. So Wellens syndrome, the description is a deeply inverted or a biphasic T wave in lead V2 and V3. It's highly specific for a stenosis of critical stenosis of LAD. Generally, when the ECG is taken, patients are free of angina. They don't have chest pain. This has happened 2-3 days prior. And they are at high risk of extensive anterior wall MI, and mortality risk is high. Please avoid stress testing. There is a high risk of MI or cardiac arrest during stress testing in these patients. Now, this is again a patient who presented to our casualty with chest discomfort. The ECG looks apparently normal, but there is a minimal ST elevation in lead 3 and AVF. Now, whenever you have this kind of a minimal ST elevation, you are left guessing whether it's a true myocardial infarction or whether it's non-specific. So whenever you have a suspected myocardial infarction of the inferior wall and you are unsure, look at lead AVL. If AVL shows a horizontal ST segment or ST segment depression, this indicates this is real. This is not non-specific. So AVL minor ST depression in the presence of ST elevation in inferior wall confirms that this is an acute myocardial infarction, and you don't need further testing. So whenever there is an ST elevation accompanied by, you need to compare this against the TP segment. There is an ST depression. You need to take them to the cath lab. This was originally described by Birnbaum and Skarlowski. Whenever there is a doubt of an inferior wall infarction, they suggest look at AVL. So ST depression in AVL is a very sensitive marker for inferior wall infarction in the acute stages. Now, whenever you have patients coming to casualty with bradycardia or even complete AV block, this is one P wave, there is a AV conduction disturbance in this patient. And if this patient has a tall peaked T wave, the diagnosis is hyperkalemia. And the reason why this ECG is important is, suppose you're in a remote place and your lab is going to give you a result in 3 hours time. Even before you get the potassium results, you need to start acting, and this patient would immediately respond if you start anti-hyperkalemic therapy. Immediate calcium gluconate, flush with saline, then in the same line, sodium bicarbonate, and if possible, give Kxalate. For the bradycardia, you need to start treating appropriately. This is you can completely save the patient if you start treating the patient even before you get the lab report. This signs can progress to asystole. If you fail to treat this, within hours, they go on to a flat line. And even putting a temporary pacemaker may not help this unless you correct the hyperkalemia and acidosis in these patients. So predominantly at lower levels of high potassium, that is potassium in the range of 5.5 and 6, you get predominant T wave changes like peak T wave. As the potassium climbs, you start seeing P wave flattening, and P waves sometimes flatly, they disappear. And when the potassium becomes more than 7, it leads to bradycardia. And this is not always one-to-one relationship. These changes can happen at a lower level of potassium when there is severe tissue acidosis. Even 7 milliequivalent can kill a patient by causing asystole, ventricular fibrillation. And worst is pulseless electrical activity. You may have a pacemaker, but you won't respond to pacing in these patients. So you need to have, and one of the clues is a patient with chronic atrial fibrillation suddenly will develop sinus rhythm. That is a sign of severe hyperkalemia. The next is a patient, 64-year-old male, known diabetic hypertensive, presents with severe heart failure. And he had prior revascularization, then thrombolysis, is on DIG Lasix and sacubitril valsartan, beta blocker, and ivabradine. And this is the ECG that was taken. So the resident who rounded on the patient increased the dose of ivabradine to 7.5 BID. Actually, this was mistaken as sinus tachycardia. What you see is multiple P waves. 1, 2, 3. For multiple P waves, there are less number of QRS complexes. So what this patient has got is atrial tachycardia with block. And one of the commonest reasons for that is digit toxicity. So the way to treat this patient is to stop the digoxin and give appropriate therapy, either in terms of antiarrhythmic therapy, or if this patient being unstable, it makes sense to immediately cardiovert this patient and restore sinus rhythm. So this is often mistaken as sinus tachycardia. And please understand, when you increase the dose of ivabradine, you will not correct this problem, but you can prolong the QT. And therefore, it is not an appropriate choice for this given patient. What I would like to impress upon is patients develop severe heart failure not due to very rapid tachycardias. Very rapid tachycardias produce hypotension, syncope, and palpitation. But slow tachycardias in the range of, say, 110, 120, but persistent, incessant tachycardia very often leads to persistent LV dysfunction and tachycardiomyopathy. So in these situations, patients don't complain of palpitation, but rather complain of dyspnea and fall in urine output. I think I've shown this. This is from our neurology center. evaluated, this is a lady who was evaluated for slurring of speech and weakness of the right upper limb, recovered. CT brain was normal. She's a known hypertensive, was a mild carotid plaque beyond the left bulb, no significant stenosis. So this patient was admitted under neurology, started on aspirin, statins, and then discharged. What was missed again in this patient was, I would like you to see this, same patient, lead V1. I put it, the first ECG is at the bottom panel. The present ECG is now P QRS, whereas here P, another P, P, another P, P, another P. The second P gets hidden as a terminal notch in the QRS. So you have a 2-to-1 atrial flutter in this patient, an elderly lady, hypertensive diabetic, and presence with TIA with an atrial arrhythmia. You should consider atrial fibrillation, transient AFib in the diagnosis. Unfortunately, this patient came back 3 months later with a dense hemiplegia, and it was most likely an AFib-related hemiplegia in this patient. This ECG was taken from a medical ICU. Patient was admitted with urosepsis, hypotensive, started on fluids, NORAD, was on antibiotics, and then this is what the monitor showed. A very nasty rhythm. So would you give IV amiodarone, magnesium sulfate, or what is the next choice? This patient was given magnesium sulfate because it's a polymorphic VT. For urosepsis, this patient was on levofloxacin. Levofloxacin can cause prolonged QT, but what is underlying is patient has an AV block. Sepsis, AV block. This is AV block triggered polymorphic VT. So this patient should be rushed to the cath lab. You need to insert a temporary pacemaker, stop Cipro or levofloxacin in this patient, and correct the acidosis. With these things, there's quite likely that everything will improve, because there is no sequential management of first, let me correct this, there. All of them need to be simultaneously addressed. Bradycardia needs to be addressed by pacing. Hyperkalemia needs to be addressed. Acidosis needs to be corrected. Offending drug, which is a quinolone, needs to be stopped. Everything has to be done simultaneously in this patient. This lady was transferred after a medical termination of pregnancy, and she presented a couple of weeks later with tachycardia, and blood pressure was 140/50. She's confused hemoglobin of 9, TLC of 9,800, creatinine of 1.8, and potassium of 4.8. And this is the electrocardiogram. B1, lead 1, 2, 3, AVR, AVL, AVF, and V1 to V6. Now, if we walk through the ECG, we can see a PQRS, but a very dramatic T-wave inversion with a prolonged QT. And this patient presented with this kind of a symptom. What should be the next step? Actually, whenever you have a febrile patient who comes to us with a wide pulse pressure, one of the things is peripheral vasodilatation. But in this patient, considering all the clinical picture, she was found to have an aortic regurgitation, and there was a cerebral, these are called typically cerebral T waves. Patient had a transient cerebral embolism, and these are called cerebral T waves. And this is typically seen in patients with any form of cerebrovascular accident. The clues are QT is prolonged, symmetric arrowhead T wave inversion, but you seldom see Q waves. But in this patient, the additional clues are wide pulse pressure suggestive of AR, post-MTP and fever, it's endocarditis. You can see junctional rhythm coming up, that indicates that there is spontaneous automaticity at the level of the roots, aortic root abscess. And finally, the diagnosis was infective endocarditis, aortic root abscess producing severe aortic regurgitation, and an embolic CVA, which resulted in those ECG changes. So if you put everything together, the reason why this is important is just giving antibiotic will not be helpful. Once there is a root abscess, without delay, this patient needs to be transferred to a peripheral tertiary care center where surgery is possible, because antibiotic alone will not enter the fibrous tissue to clear the infection. The aortic root is a fibrous structure, and that needs to be surgically corrected. 47-year-old person with chest pain, history of smoking, and occasional alcohol, presence with chest pain after a brief febrile illness. And this patient was quite symptomatic in terms of both chest pain. He was tossing and presented with breathlessness because he was little tachypneic. The clue here is the diagnosis. Whenever you see a tachycardia with diffuse STT changes and the PR segment in AVR is elevated and compared to the ST segment, these things. So what is this? If you see an ST segment is depressed, but PR segment is elevated, and that should make you suspect with a diffuse ST elevation, it should make you suspect a pericardial effusion. Now, the reason why this is an important differential is if you don't have this in your differential and you give a dose of heparin and antiplatelets, quite likely the patient will develop tamponade because of an increasing tendency for bleeding. Certain conditions, even with near normal platelet count, there will be a higher tendency for bleeding in the pericardium, like if there's an autoimmune disorder or dengue fever, or some of them which are associated with increased hemorrhagic tendency of some of the viral fevers. The beauty is once you recognize and take the fluid out, the QRS normalizes, the ST segment slowly comes back to normal, and everything results in a satisfactory outcome. This patient had transient dizziness and was referred with the idea of getting a pacemaker because someone noticed a pause in this. This is an ECG where I would like to draw attention. Whenever there is a pause, this is a normal PP interval. And then this P to this P, there is a very long delay. One of the commonest thing that gets overlooked is a hidden P wave. And the best place to look at it is in the beat that precedes, that is the pause. The first beat of the pause, the T wave will be distorted. So compare the morphology of the T wave of the previous beat and this beat. You find that this T wave is different from this. It is different because a P wave gets buried here. This is a very early APD, which comes very early before the AV node has recovered, and therefore it gets blocked in the AV node. Then it takes a long time for the sinus node to recover, and that is the reason for the pause. So one of the common reasons for long pauses in a given patient is blocked PAC, and this doesn't need any treatment. The patient is symptomatic, you can give a beta blocker, it will suppress the PVC. Or if it's very refractory, you can even start antiarrhythmic therapy for these patients. This is a patient with dilated cardiomyopathy, had palpitation, and he was admitted in the hospital, and on the monitor, this was recorded. EF of 45%, his resting pulse rate was normal, blood pressure was normal, he had a prior coronaries which were normal, coronary angiogram, and this was the reading. So how would we treat this patient? We had a very interesting discussion in the previous session about the role of ICD. Should we give an ICD, or Dr. Panja raised the issue of doing an MRI or increase the beta blocker? Now, this is important. Very often in Holter monitoring, This is a QRS, this is a QRS. Whenever you see a baseline drift or a wander, you should suspect that there is an artifact. And the clue to that is you need to march the rhythm backward, measure the caliper, this RR interval, go back in time and look at the next RR. So there is a QRS hidden here. This is called a spike sign. It looks like a spike in between. You cannot have a depolarization and depolarization again. It has to be followed by repolarization. So you can see some spikes. The clue here, for some reason this doesn't move. Sinus sign is in an ECG, one of the frontal leads generally shows normal PQRS. Spike sign is what I showed you. Tiny spikes can be marched along among the white QRS. You may see this. Sometimes when the artifactual QRS is wide, you can see the native QRS falling there and it causes a notch. So that's called as a notch sign. So you see these spikes and notches. And if you take a caliper and march from the QRS, you will be able to march within the white QRS. And this shouldn't be mistaken as a VT. This is just an artifact. And you need to take a decision regarding, you can ignore this as far as this is concerned. It's an artifact. Way to avoid this is please make sure that the telemetry electrodes or Holter monitoring electrodes are not placed on the muscle, but on bony points. You'll avoid these problems. I think I'll stop there and thank you very much for the patient listening.
Thank you, sir. Thank you for your excellent deliberation. You are always a great teacher, and it's quite very good for us to learn from you all the tips and tricks of ECG nuances. And I thank Dr. Narsimhan once again. Dr. Bera, do you have to give any input?
Munna, there is a question from Dr. Jamil Abdul that do we have to give synchronized or asynchronized DC cardioversion in torsades? So if sir can take that.
Yeah, it's async because if you try to synchronize, it will delay the therapy. It keeps on changing the points, so you cannot synchronize. It's a defibrillation.
Yes, sir.
So absolutely, because in the guidelines we have that any patients with VF or polymorphic VT should be treated with defibrillation.
Dr. Narsimhan, thank you for your gracious presence.
Thank you. I enjoyed it. Thank you.
17th year, in each year you have come to the UCD. Thank you very much.
Thank you.